I'm Dr. Tracy Stecker, and I'm here today with Dr. Lisham Ashrafioun, who is a psychologist and a researcher at the University of Rochester's Medical Center and at the Center of Excellence for Suicide Prevention at VA. He is a expert on suicide, pain, substance use disorders, and loneliness. And today we're going to talk about pain and social disconnection. So, Lee, you and I have talked about this quite a bit. There really are three issues going on in terms of pain and social disconnection. People are having physical pain, people are isolating and feeling alone. And then there's an interaction between those two things, those two issues. Would you take us through all three of those briefly?
Yeah, absolutely. So just thanks for having me. We've had many discussions about this topic, and I'm excited to kind of talk about it with a broader audience. So chronic pain, really has, a significant impact on people. So you think of like pain conditions like chronic back pain, arthritis, migraines. These are leading causes of disability. And we find that about a fifth of U.S. adults actually experience some kind of chronic pain.
Hmm.
Now, there's also a subset of this group. So about 8% experience something that we refer to as high impact chronic pain. And this is chronic pain that really limits daily activities. So these are gonna be things like people's hobbies, their work, performing household activities or chores. In this group too, we find that, the severity of pain is typically worse, and it's also accompanied with mental health concerns too. And so, with both chronic pain and this high impact chronic pain, you get this massive economic cost of chronic pain with over $500 billion that is from lost productivity at work, healthcare utilization, etc. And then chronic pain, of course, is, it's associated with things like addiction and mental health conditions and, unfortunately, suicide risk as well.
Devastating. Yeah.
Yeah. Yeah. It's pretty um, widespread, and it really can have a significant impact on people's lives. Now, in terms of loneliness, first I think it's really important to touch on the difference between isolation and loneliness.
Hmm.
And so when we think about loneliness, we really want to try and differentiate it a little bit from being isolated. So when somebody's isolated, so they might have sort of few social contacts. It's likely that they, could be lonely, but it may not be the case.
Hmm.
And then you can think, that person could be, satisfied essentially with having few social contacts. And so they're isolated and not necessarily lonely. And then, other times you could have, you may think of somebody who has plenty of social contact with other people, but for whatever reason, um, maybe it's the connections that they have with people are not important or meaningful to them, and so they feel lonely. And so again, so being isolated and being lonely, they may be related, but they're not necessarily the same. And in terms of its impact, like with chronic pain, loneliness is common and it's growing, and it has this significant public health impact. And so studies have found that it can increase risk of death, and it also leads to unhealthy behaviors, worsening physical and mental health problems. And we actually see some pretty similar results when people are isolated as well.
Okay,
Um,
so it's the
yeah,
quality of the interactions rather than quantity, and poor quality, perceived poor quality, can have catastrophic events. I mean, catastrophic consequences on that
yeah,
individual. Okay.
yes, absolutely. So, many of the people that we've talked to, they may have a wife and kids that they live with. They may have a job and stuff like that, and yet for one reason or the other, um, they're not satisfied with the connections that they have, and so
Hmm.
even though they have sort of rich social contacts with people,
Hmm.
they still report loneliness, and that loneliness can lead to, um, unhealthy behaviors. Whether it's, substance use, it can also end up leading to isolation as well. Um, it's linked to smoking cigarettes and sedentary behavior. So loneliness itself can have a wide range of significant impacts.
And I know you're not here to talk about this, but necessarily, but I understand there's physiological data for, and when you're studying people who identify as lonely, the brain chemistry is different. There are actual physiological effects of
Yeah,
loneliness.
certainly, certainly. And there's been studies showing that their how how their brain reacts to different social stimuli, ones that are
Hmm.
typically, rewarding and pleasurable,
Hmm.
is not nearly as pronounced compared to people who are not lonely. So they
Wow.
don't get that same sort of reaction that people who are not lonely get when they are confronted with cues that are typically positive social cues.
Right. Great. Okay. Now the interaction.
Yes, the interaction, of course. So again, both of these things on their own can really kind of wreak havoc on people's lives and their health. And unfortunately, we find that, and perhaps unsurprisingly, we find that loneliness is associated with the development of chronic pain. And then people with chronic pain are more likely to be lonely compared to people without chronic pain. And so when someone is experiencing both of these, it really tends to lead to worse outcomes. So it predicts lower levels of physical functioning and greater pain-related interference in activities. People with chronic pain reporting loneliness um, report a greater number of sick days from work, and they're more likely to report thoughts of suicide. And then it's also associated with lower life satisfaction, higher depression, and less mobility. And so again, these are people, within people who have chronic pain. So comparing people with chronic pain who are also lonely to people just with chronic pain, we really see this increase in worse outcomes. And so ultimately, this combination is really problematic for their well-being and health overall.
Oh, Lee. Okay, so what can we do about it? How are we addressing this?
Yeah, I always this always ends up happening in like every talk I give. I paint this like very bleak picture, but like there's opportunities for intervention and really kind of helping people out both with chronic pain, loneliness, and their interaction. And so, I typically take this, a biopsychosocial approach. And so this approach takes into consideration the biology, so the physical damage or the disease,
Hmm.
the psychological factors, so our emotions, our thoughts, our behaviors, or what we're doing, and then social context as well, what we're doing with people around us. Um, and so we think about, how these factors can impact pain and also be impacted by pain. And so historically, or actually often in practice now, pain is addressed through a biomedical approach. And so
Hmm.
these are things like surgery, medications, injections, etc. Um, and so, this type of approach, you can think of how it may have led to an over-reliance on prescription opioids,
Hmm.
which have had devastating effects on addiction and overdose, unfortunately. But now there's been some, a little bit more of a shift to non-opioid pain relievers, like uh, acetaminophen or Tylenol, ibuprofen, etc. And then we also want to kind of highlight the psychosocial aspects. And so there's interventions that focus on that. And so, for instance, there's ways to change our thoughts or how we think about how our pain can impact how we feel and what we do. And so someone might have this thought of, I'm worthless because of my pain. And this, of course, is likely, coming along with negative emotions like depression or sadness. And something like that can lead to people withdrawing and isolating from people.
Hmm.
And so with psychosocial interventions like cognitive behavioral therapy, as a therapist, I can help some, patients identify these types of thoughts and modify them to be something that's, maybe a bit more accurate or helpful even. And so shifting the thought to something like, pain challenges me every day, but I can still enjoy my time with my family. Still allow that person to acknowledge the difficulty of their situation, but also that, acknowledges for the, uh, or allows them the opportunity to engage with others as being, a helpful and even enjoyable activity.
Hmm.
Um, and so, the other, sort of aspect of these cognitive behavioral interventions are, working with the person to identify activities with which the person can engage, and then, approaching them in a way to avoid, things like pain flares
Hmm.
from cropping up, really aggravating their pain. So you're doing it in sort of a systematic kind of way that's going to reduce the chances of being overactive or something like that. I remember my aunt had, low back pain, and when she felt good, she was moving furniture all around her house. Probably not the best thing for, an 80-year-old person who with chronic back pain to be doing.
But she could do
And
it.
she could do it, yeah, but then
Hmm.
she would be out of commission for the next week because she couldn't move.
Right.
And so the cognitive behavioral therapy is going to be working with the person to identify, um, a way of approaching these types of activities, but things that aren't going to put them out of commission for a week.
Right.
So doing things sort of in a slower, systematic way so that they're still active, but not something that's going to completely overwhelm their body, essentially.
So instead of focusing on what they can't do, I can't anymore because I have this condition. I can't do that. I can't do that. And instead of feeling like they're not being productive or not being helpful, focusing a little bit more or in addition to on what they can do. You can
Yeah,
still do that.
absolutely.
And maybe there's some boundaries around it. Maybe you set it up a little bit differently. So she's not moving the couch by herself, but she has help to move it. She's still in it.
Yes. Yes, exactly. So there's just so many times where people describe like, not being able, I can't be a good parent or I can't be
Hmm.
a good grandparent because I can't, run around with them or something. Okay, well,
Right.
you can't run around with them, but what can you do with them?
Hmm.
And that doesn't mean like just because you can't run around with them doesn't mean you have this blanket statement of I'm a bad parent now.
Hmm.
And so what happens a lot of times if they can't do this one thing or even a range of things.
Hmm.
And so they'll just withdraw from others and they'll isolate from people as a result. And instead, we can work with them and help them understand that like, okay, maybe you can't run around with them, but maybe there's a board game that you could play, or, maybe it's just sitting down and talking with them to learn about their day. And that's a way to still be a good friend or family member to the person,
Yeah.
rather than isolating or something like that.
Well, and I can think too, just working with people who have been in, who have had chronic pain, there's such extensive sleep disturbance. So it's very hard to have positive thoughts really about anything because it's hard to sleep and you don't feel well. You're in pain. And so those two things also interact with the mind's ability to think clearly and to consider what they still do have, what's still working for them, what support they could access. They're just thinking, oh, it's too
So,
hard.
yes, yeah, 100%.
Hmm. Sorry, I distracted you.
No, no, no,
Okay.
you're good. You're right. I mean, they're huge. Sleep and pain co-occur a lot. And
Hmm.
just like with loneliness, you add, sleep disturbance to pain, and it's really going to kind of impact all these kinds of things in a negative way as well.
Hmm.
And so, fortunately, we do find that there's um, sleep interventions also utilizing similar cognitive behavioral approaches
Hmm.
that can help people with chronic pain as well, not just, people with sleep disturbance more broadly.
Okay, so the biopsychosocial model, going back to that, the biological interventions are widely used for chronic pain.
Yep.
Psychosocial interventions are available, and there's scientific evidence that they're helpful and work, correct?
Yeah. Yeah. So, they fortunately these psychosocial interventions like cognitive behavioral therapy, they find that there's sort of nice effects in terms of not just improving pain outcomes, like, decreasing pain-related interference in activities,
Hmm.
um, but it also improves things like depression and anxiety as well. And so we
Okay.
see that there's broader effects beyond just its effects on pain, but also in other areas. Now, the sort of the unfortunate piece, and I kind of hinted at this before, is that these the biomedical approaches
Hmm.
continue to be sort of the primary
Front line.
frontline approach, which is great. Like, there should be. They are effective in many ways as well. At the same time, though, these psychosocial interventions are also kind of impacting two of those main factors of the biopsychosocial model. And so, unfortunately, they are sort of greatly underutilized. Um, and that comes from a variety of things. So sometimes there's lack of availability of them in certain places or areas. Just, fewer providers deliver that type of intervention.
Hmm.
And then there's also just sort of a lot of people just don't know about them, including healthcare providers too. So,
Hmm.
um, certainly um, having wider access and availability and also knowledge about these is going to be important. But one of the huge things that we have come to learn, and what we find in the literature too, is that people's thoughts about these treatments also impact their ability to start them or
Right.
even
Like
seek them out to
I don't
begin
need
with.
therapy. I'm not going to therapy. Is that right?
Yeah, exactly. Yeah.
Hmm.
Yeah, and for pain as well, it's just a hard thing for some people to kind of wrap their heads around.
Hmm.
Like, I have this physical problem
Hmm.
that's interfering with things in my life. How
Hmm.
is talking with somebody gonna help about that? Gonna help with that?
Yeah. Talking's
There's
not
just
going to fix my bone, kind of.
Yeah, yeah,
Mhm.
exactly. There's still sort of like a stigma attached to seeing a psychotherapist as well, and
Hmm.
so people might avoid this type of treatment because people will think I'm crazy if I am seeing a psychologist or social worker. Um,
So
you know,
stay in there for a second. Talking might not fix the bone,
yep,
but it kind of does.
it does. Yeah. So again, it's not going to repair a broken ankle,
Hmm.
right? But the important thing to kind of think about, and this is the analogy I always use with people that I work with. So for the biopsychosocial model, the psychosocial factors it's not like a light switch, where if you address somebody's thoughts or you reduce their depression, it may not necessarily, you can't just flick the light switch off and their pain is gone.
Right.
But if you think about it as like a dial on a stereo or like a dimmer switch on a light,
Hmm.
if you reduce some of that depression or you kind of have people think about their situation in a more accurate or helpful kind of way, it's going to tone that dial down a bit more.
Mm-hmm.
Um, and so a lot of a lot of the initial sessions of CBT for chronic pain, they're going to focus on um, helping people understand this biopsychosocial model and the biopsychosocial approach, and learn that, like, again, we're not trying to uh, completely turn the pain off. We're going to just tone it down a bit. We're going to change people's experience
I can't stop.
of the
I can't
pain.
stop laughing. Come to see Dr. Lee. He's not the light switch. He's the dimmer switch.
That's right. That's right.
But it's
I'm very
really critically important when
dim
you
it.
think about it.
Yes.
Because sometimes that's all you need. If you're in pain and you're, not feeling comfortable working or interact socializing, or
Yeah.
even asking for help, sometimes all you need is just a little bit of that pain turned down to really motivate you to call for help, to call a friend, to call a loved one, to get outside, to try and do things. So that dimmer switch, I know I laughed at it for a second, but it's critical. I mean, that sometimes that's all any of us need just to be able to move again.
Yeah, totally. So, I mean, a lot of it relates to, um, some of the issues to begin with. So, a lot of times when we aren't feeling good,
Hmm.
we think of things as like, black or white or all or nothing. And so the dimmer switch analogy also, brings in more nuance or gray area, because
Hmm.
that gray area is going to be important, so maybe my depression level or my sadness is at a 10. And
Right.
if I'm just turning down the intensity of my thoughts just a little bit, or the
Yeah.
intensity of my emotions a little bit, then maybe that's enough for me to, I don't go and talk to my one of my friends, or just even text a
Right.
friend or something like that.
Right.
And then if I text a friend, then, maybe they help me feel a little bit, or we laugh about something, or,
Hmm.
and then here I am, a second ago, I was at a depression level of 10 and I'm laughing. And that
Hmm.
may not have never happened if I, um, thought about the situation as all or nothing. I brought nuance and gray area into it.
Yeah. Sorry, I hope you can't hear my dog in the background barking.
I usually can, but not today.
Oh, good. Thank goodness. Okay, so we have this this epidemic of loneliness. We have chronic pain is catastrophic. We have a fifth of the country struggling with these conditions. We have interventions for them, both biological interventions and psychosocial interventions. And then we also have beliefs that are getting in the way of people accessing these beliefs. So, are there any ways to help somebody who might otherwise benefit from these interventions try them?
Sure,
What can we do to help them at least give it a try?
sure. So if it if it hasn't been made painfully obvious, I'm a proponent of cognitive behavioral interventions.
Hmm. Same.
Yes, yes. And so a lot of these strategies are really kind of applicable across a wide range of things.
Hmm.
And to me, seeking treatment is, another way in which we can kind of uh, is another thing that we can approach with cognitive behavioral strategies. And so, if we are identifying these beliefs or thoughts that are really kind of acting as barriers for people to
Hmm.
engage
Hmm.
in a variety of other pain treatments that are available, then, cognitive behavioral approaches are a way to do that. And
So
so
if
we can.
somebody says, I don't need therapy, I have my pain meds. All I need to manage my pain is my pain meds. How would you help them maybe think about it in a different way?
Yeah, so typically when they are kind of saying things like that, at this
Hmm.
point I will have already kind of collected, or I know a fair amount about them.
Uh-huh.
And so typically they have talked about being on these medications, but also there's all this other kind of ways in which their impairment or their functioning has been impaired.
So
And
it's
so,
helping, but not quite enough.
yeah, and
Yeah.
they've kind of discussed this dissatisfaction with like, they want to have more. Their quality
Hmm.
of life isn't what they are where it is right now. They
Hmm.
want to be able to improve that still.
Hmm.
And so maybe the medications have helped a little bit, but they haven't got them to, the mark where they're really seeking. And
Yeah.
so, it can kind of bring up a conversation like that, and that it helps them, might be sort of a reminder to them.
Hmm.
But it gets them talking about how, okay, well, maybe I do like my medications for right now, and
Hmm.
um, maybe a little something else could be helpful too.
Right. And so going to therapy, like a CBT for pain, doesn't necessarily mean anybody's taking away your medications. It's just another way of helping somebody maybe modify their thoughts about their pain
Yeah.
because it's not just the actual experience of pain, it is what that pain has done to their life. So that helps them change the way they're thinking about it a little bit.
Yeah, yeah, absolutely. And that's also where sort of discussion of the biopsychosocial model could be helpful too.
Hmm. Yeah, I
Where
could see how it'd be.
you highlight some of going back to the dimmer switch, you
Hmm.
highlight some of these psychosocial factors and how other types of non-medication interventions can be helpful by addressing some of these psychosocial factors too and
Hmm.
turning the pain dial down a bit.
I love it. I love
Yeah.
it. So for those who have loved ones or themselves who are struggling with chronic pain and who might be feeling alone, there are resources available. Dr. Lee is here. I'm here.
Yeah, absolutely.
On our website, we have a resources tab if anybody wants to check out additional resources or contact one of the two of us, please feel free to do so on the choosinghelp.com website. Thanks for being here, Lee. This was
Yeah.
great.
Thank you. This was fantastic and always happy to help out and discuss things with you and others.
Any last words? Anything we missed?
No, so I'm just sort of highlighted cognitive behavioral therapy, but there's also things like mindfulness based
Hmm.
approaches that are very helpful for people as well. And
Hmm.
so that's just sort of a way to be in the present moment and understand that like the pain in your knee is just the pain in your knee and you have the rest of your body as well.
Yeah,
And so what happens a lot of times is when understandably if we have a lot of pain in one area we forget about the rest of our body.
right.
um, and so it's important to kind of think about it as our body as a whole. And so some
Hmm.
of these mindfulness based approaches do that as well.
Yeah.
But again, are underutilized as well. So,
Hmm. Good point. I'm glad I asked if there was anything else. Well, thanks for being here.
all right, thank you.
Bye, everyone.